I wanted to talk to you guys. You know, this is supposed to be the technology session, so I figured I would show you guys some technology. Mainly the stuff that I'm very interested in, or part of the stuff I'm very interested in, is fluorescence-guided surgery. And we've talked a little bit about this in the NeuroOnc conferences, but I wanted to talk about it again, a little bit more specifically. All right, can everyone anticipate what I'm going to say next?
We can see it.
Yeah, damn right. Did people get it or no? I swear to God, t-shirts are going to be made that say, can everyone see my screen? Anyway, so I will preface this with this. Fluorescein is no longer my drug of choice, but this is where I started my research into this kind of novel stuff and kind of began to appreciate how cool this is for the future. All right. And so fluorescein is just one of the ideas. And so here's a brief outline. This is going to be shorter than this. All right, so the main thing to understand though, and if you get one thing out of all of our NeuroOnc lectures, and specifically gliomas and glioblastomas, is that extent of resection matters, right? More is more, all right? And so modern glioma surgery, as we treat it now, is evolving around this idea of safe maximal resection, okay? If you give someone a deficit, they will not live as long, all right? They will not do as well, so you have to be safe. But you also want to get out as much tumor as you can, and actually supratotal resection is becoming sort of the standard when you can. And that means not just the contrast enhancing tumor that you see on the MRI, but an area of the brain around it, because the majority of recurrences occur within 2 centimeters. But when you look at these old studies, cells actually travel all the way through the white matter. There's cells on the other side of the brain, even at diagnosis. So, you know, ultimately, glioblastoma, gliomas are not surgical diseases. These will be medically treated. But surgeons have made great strides in guaranteeing that people do well. The other thing that'll mean that makes sure that surgery will never go away is a lot of these things occur in clinically silent areas, meaning that the right frontal lobe, you can develop a pretty sizable tumor before you ever know that you have one. And so patients will always need surgery to remove these things, to debulk them, to minimize how much tumor is there. And so, but the bottom line is safe maximal resection. And the other thing that's really cool about safe maximal resection, or important about it, is that this is a modifiable risk factor, okay? So when you look at the prognosticators of GBM or gliomas, age, can't change it no matter how much Botox you get, functional status, how much you deteriorate. That really determines how well can you live on your own and be a human being by yourself, basically. Do you depend on others or not? Histology, can't change it yet. Molecular markers, can't change it. Extent of resection, we can actively go in there and change what we do as surgeons. All right. This slide is absurd. I'm sorry I ever made it. I'm sorry any of you have to look at it. But what it is, you know, based on a review that I had written a while ago, talking about extent of resection in the literature and reviewing all these papers that have looked at this. And the bottom line is that, again, with greater extent of resection, and the studies show about 70 to 80%, meaning you get 70 to 80% of the tumor out, you're going to have a meaningful improvement in overall survival, progression-free survival, quality of life, okay? And then they looked at this in recurrences, and it turns out if a tumor recurs and you go back and do the same thing, get out as much tumor as you can, you're going to improve those outcomes. Overall survival, progression-free survival, quality of life. And then they looked at it in low-grade glioma. All right, and it was the same thing. And so this is a big deal. It means that debulking the tumor, and if you think about it, it makes a ton of sense, right? You're just minimizing how much disease you have to treat with chemotherapy and radiation, right? So you want to be aggressive about these things, but the data supports it. Now, caveat, this is not a clinical trial. There's no clinical trial that's ever looked at this. This is not what we call grade 1 data, all right? This is data compiled from large case series, retrospective reviews, some prospective studies, but it's strong. And again, it really guides the neuro-oncology community in terms of how we deal with this stuff. All right. So someone asked, what is EOR? And I kind of ignored it because here it is. So extent of resection is EOR. And how do we measure that? So contrast enhancement is the first thing for glioblastomas, okay? Contrast is a dye that's given intravenously when you get an MRI. It extravasates in areas of blood-brain barrier breakdown, which is very common in these tumors, and it lingers for a little bit, and so it lights up an area of the tumor. But like we said before, the tumor cells have infiltrated, and a single cell over here hasn't disrupted the environment enough to cause blood-brain barrier breakdown. And that's why things like intraarterial therapy with, Dr. Bookvar's device is important, because you want to treat these areas as well. And so that's an important thing. So when most of the studies look at extended resection as resection of the contrast enhancing region. Now, the T2 flare region, that has to do with edema. So all these tumors create swelling around it, and there are cells within the swelling. So that's something people look at as well. Low-grade gliomas do not enhance. Infiltrated brain does not enhance, again, because the blood-brain barrier is not, fully disturbed. And so what do we talk about with volume there? And the bottom line, the takeaway from this is that reliance on this contrast enhancement is going to underestimate the extent of the tumor burden, okay? So you're gonna always think that there's less tumor than there really is. So what do we need? Oh, this is actually a good image. So this is what a brain tumor looks like that comes to the surface, okay? Right, so we look at this in the operating room, and I can tell a little bit where it is, but I can't see the full extent because the brain tumor, it's infiltrative. It looks just like the normal brain. And so again, this is a little bit easier. You can kind of see this outline where it's a little hyperemic maybe, meaning a little bit more red, a little bit more bulgy, okay? But then we start taking it out. And then it looks like this. And I defy anyone here to be able to tell me that you can tell what's tumor and what's not here, right? So maybe down here it's a little bit discolored. It takes experience, okay? Or it takes something else. So what is that something else? All right, so we have all these intraoperative adjuncts, right? We've got ultrasound, which I showed you guys the other day, all right? You can use that grossly to see the tumor. We've got navigation, which again is millimeter accuracy based on surface landmarks, okay? Some places have intraoperative MRI. So actually you take out tumor, and then in the operating room, they do an MRI and they see if there's any residual, and you go back in and take out more if you left any. Mapping is a little bit different. This actually identifies the places you need to preserve, not so much what's tumor, all right? But absolutely critical if things are in areas that are really important to preserve for patients' functional status, because again, how well you are after surgery is gonna contribute to how long you live. And then everyone loves, or I love, and I bring it back all the time. But this is the main problem. This is the crux of the issue, right? Brain good, tumor bad. When you're looking in real time, how do you figure out what's what? Right? And so there's been a ton of research now into ways that we can do this. All right. And what people realized was we could change the color of the tumor maybe. Using fluorophores that have been looked at in other types of surgery. All right, and now all of a sudden it stands out what you're looking for and how to preserve it. All right. So fluorescence guided resection. This is used now in all types of surgery, not just neurosurgery, but I think that we definitely probably gain one of the most benefits from it. 5-ALA was really the first drug, came out of Germany, and this is actually a prodrug, which means that you drink it and then it kind of jumps in the normal kind of molecular cascade metabolic cascade of the cells, and they convert it into a protein that is fluorescent. All right, and that means that when you shine light on it, that metabolite basically gains energy from the light and then releases it at a different wavelength. All right, and so Gliolan is the name of the drug, 5-ALA. It's approved by the FDA for grade 3 and grade 4 tumors, and it's great. It colors the tumor red. All right, and so now you flip a switch on the microscope, which is fitted with a special filter, and the tumor turns red and the rest of the brain stays basically dark blue. And now you can identify boundaries. And so you can see actually where it infiltrates into the brain. It starts getting from a bright red into a lighter pink, lighter pink, lighter pink. And that has to do really with dilution of the cells. You just can't see a single cell in a sea of normal brain, right? It's like peeing in the ocean, right? So basically, you follow the dark red stuff, and you know that that's going to be the enhancing boundary, all right? And people have looked at this, and the evidence for this is great, all right? It increases your extended resection. People using this that get higher extensive resection, they also get improved survival, both progression-free and overall. It's got, it turns out that it probably guides you beyond the contrast enhancing boundary, which is, again, remember, the cells are beyond that. Enhancement only means blood-brain barrier breakdown. But cells that are metabolically active are still accumulating the fluorescent metabolites of 5-ALA. And so it actually guides you a little bit further. You get more tumor out when you use this, right? But it's expensive. It's about $1,500, I think, a vial. It's not everywhere right now. And it can lead to some light sensitivity, although very, very rare and unlikely. All right, this is a drug. You actually drink this about 4 hours before surgery. All right, sodium fluorescein is another drug. And this is the one that, I studied at least in residency. This has been around since the 40s. People used to give a high dose, and you could actually see the tumor fluoresce just by looking at it with your bare eyes. But then we learned that we could give lower doses, and the microscope actually would help us with using these fluorescent filters. And so the thing here is that it's extremely bright. So with 5-ALA, you notice that was really dark. It was dark field. You can't really operate under that. You can switch it on, switch it off, switch it on, switch it off. With fluorescein, though, you can actually operate under the fluorescent light, and that's helpful. So this is what this looks like, all right, in real time. Hold on, guys. Give me 1 second. I'm sorry. Someone's knocking on my door. Watch this for a second. Hey, I'm in the middle of the lecture. Give me about a half hour. Anyway, so you can see here, this is actually the tumor boundary where it comes to the surface, okay? And this is part of a study that we did. We're taking samples of tissue from the non-fluorescent boundary and non-enhancing boundary. And we sent all these specimens for pathologic analysis to kind of characterize how accurate this fluorescence was. All right, you can see now we're taking a biopsy from the tumor. We're actually, you see, we're not cauterizing a lot because we don't want to ruin the tissue, so it will bleed a little bit, but then we'll take care of all that. And then you go in and you debulk, and you basically, it's almost like reverse paint by numbers, right? You remove by color. So we did this way back when, and you can see we took about 90 biopsies between 26 patients. I think the actual number was higher, it was like 30 something. And what we found was that the sensitivity and specificity of this was pretty good. It's about 75% in all samples, but that went up to about almost 90% when you were in areas of contrast enhancement, and then about 70%, lowered a little bit in the non-enhancing areas. And this gets to what some people are saying, that there is some fluorescence outside of the tumor boundary when you use fluorescein, okay? 5-ALA is much more specific. Again, it is metabolized in the tumor cell itself. Fluorescein relies on blood-brain barrier breakdown, like contrast. So fluorescein is really an intraoperative contrast agent, whereas 5-ALA is an intraoperative, cell identification method or visualization method. All right, I'm not going to bore you too much with the stats because the main thing here is to say, wow, that's cool. One thing that we looked at, which I thought was very cool, is we looked at extended resection with fluorescein and non-fluorescein. So we used basically case match controls that had been previously operated on. And you got to remember, so I trained at Columbia with a bunch of world famous neurosurgeons who were very experienced at this. And when we looked at our numbers, our gross total resection rate using fluorescein, which is without a doubt an imperfect fluorophore, raised to 93% from 77%. So that's incredibly interesting. These guys are extremely skilled surgeons, and we were able to make them better. And actually, a funny quote is, I brought 5-ALA to Lennox when I first came here. And Dr. Bookvar initially, wasn't trained with it, didn't really believe in it that much. And he used it, and he called me and he said, Randy, I didn't know I could be a better surgeon, and just loved it. So it's an insurance policy without a doubt. This is the evidence supporting it. This is basically just corroborates what we saw in our paper. All the sensitivities and specificities for fluorescein are in the same range, basically. So dosing matters. All right, we use a low dose because you don't want to overwhelm the tumor. If you do high dose, there's a lot more bleeding. Fluorescein exists in two states. It's either bound to albumin or it's not bound. the bound form can't actually get through the blood-brain barrier, and the unbound form can go back and forth. And so you want to give just a low enough dose so that you don't saturate all this binding and whatnot. And then timing matters because it actually goes everywhere at first and then gradually washes out. So you really do want to wait with a low dose about an hour until you start, relying on it to be sensitive. What is timing wise? This was just, our biopsies were taken over the course of surgeries. And basically what we showed was, up to 220 minutes and beyond, you still maintained your sensitivity and specificity. And so we looked at other tumors and specifically low-grade gliomas. Low-grade gliomas are really the crown jewel of all this stuff. If you can find a way to make a low-grade glioma glow in the dark and make it easier to resect and find all of it, you're going to do wonders for the field because external resection matters. These patients have great outcomes that are long-term outcomes. And so the difficult thing is that they're infiltrative tumors. They're really infiltrative. There's normal brain in between tumor cells. In a GBM, that's not really the case. The GBM kind of overwhelms and overtakes and incorporates everything around it. And so what we found, though, is that 5-ALA is not too great for low-grade gliomas. The one thing that's important, though, is when you look at a low-grade glioma and there's a part of it that lights up, that part that lights up is actually probably a higher grade focus within that tumor. And that's important because it changes how we treat the tumor. We always treat according to the highest grade. So if you have someone who the tumor is, 80% grade 2, but there's a focus of grade 3, it's transforming in one area, you would treat as a grade 3. And that's critical to understand. Metastases intermittently fluoresce. Meningiomas high, but it's really not specific. And then biopsy is an interesting thing too, where now we can actually limit OR time by sending a needle into the brain, taking out a piece of tumor, making it glow, and that's pretty much a guarantee that we have lesional tissue. You didn't miss your target, especially for small little lesions. This was a study we did looking at the low grades, and this kind of corroborates what we've seen with 5-ALA too, which is that, again, fluorescence amidst a low-grade tumor usually means a higher grade component, all right? Someone just asked what makes a tumor low or high grade. We talked about this in the glioma talk. Remember, these are things like vascular proliferation, necrosis, cytologic atypia, higher cell turnover, mitotic rate, things like that. All right. This is just more for other tumors, kind of boring. So the bottom line is this stuff helps, all right? Fluorescein does help. I actually use this at Wyckoff, which is a hospital with less, financial stability than Lenox Hill. And so this is a cheap drug. A vial of fluorescein costs about $15. A vial of 5-ALA costs about $1,500, right? So huge issue. It's safe. It doesn't have any side effects. Neither does 5-ALA really. You have to be careful with fluorescein because it'll stain outside of the tumor boundary as it leaks through, and over time that leakage will get worse, and also with manipulation of the brain it'll get worse. All right, but it does help, and with some experience you can use this to maximize and improve external resection. There's a little bit of a learning curve. This last statement's huge. This is not a cure, it's insurance, and right, so you do your normal surgery that you're trained how to do, and then you light it up and you say, did I leave anything? That maybe confused me a little bit. And so it's just an additional tool that we have in our armamentarium, and we're getting better at using these things. All right, the future of fluorescence, and this is why this is important. This is important for you guys who are getting into the field, who are going to get excited by this stuff, okay? Multiple fluorophores. You can attach antigens to these things, or antibodies that target specific proteins within certain cells. So let's say a GBM is found, 100% of GBMs express a certain protein. You could actually create a fluorophore that targets that protein, right? Now, that's not the case right now, but it's possible. There can be very specific, very targeted. There's precision labeling. This is real time, all right? When you use navigation, the minute you take the skull off, the brain moves. Your navigation's off. Remember, it was a scalp registration. You're now 1.5 centimeters deep to the scalp, right? So things can change. Also, as you resect tumor, the brain moves. So this is real time. You get to see with your own eyes what's colored, all right? People are looking into lighting up normal structures, which would be critical for things like cranial nerves, if a tumor is involving cranial nerves. Find the good nerve amidst the bad tumor and preserve it, right? Digital scopes have changed the game. Augmented reality now exists where you actually can, through your viewfinder on the exoscope or the microscope, overlay the fluorescent image. So you're operating in real time. You can change the color of it. You can do whatever you want with it. And then one thing that I'm super interested in is artificial intelligence for this. Sorry, it's the same thing. And so what we had found was actually just using a really simple way of looking at the fluorescence on a digital scope. We were able to say that we set basically a normalized, intensity, and anything above an intensity of 0.1 was essentially 100% specific for tumor. Now, we did this, after the fact on a computer, but there's no reason a microscope can't do this for you, right? So fluorescence coming from the tumor is automatically segmented, and anything above a certain fluorescence is 100% guaranteed to be tumor, right? And so all of a sudden your microscope can tell you what to resect and what it can't, right? I can't imagine that that's far away from happening. Extended treatment. So this is an idea that I have. This is kind of what guides my interest. So I'm interested in, intraoperative adjuncts, and then ways to deliver therapy to the brain. That's why intraarterial is so important. Extended resection is limited, like I told you. 50% of tumors have already reached the contralateral hemisphere by diagnosis. That's crazy, right? It means that when you see a big GBM, 50% of those patients have cells on the other side, right? And so people anticipated this problem, and Walter Dandy, who's a famous neurosurgeon, did hemispherectomies in the 1920s. And it turns out that people did extremely poorly. I think his best was 1 year survival after that. And the real truth of the matter is that these guys in the 1920s weren't doing 20/20 neurosurgery, right? They were ripping out half the hemisphere. God knows how these people were. They were probably too sick to do well. Remember, performance matters. And so we've gotten much better at this, all right? But at the end of the day, recurrence is the rule, right? I told you guys the other day, the issue is it's like spaghetti sauce, right? You can remove the meatballs, but the sauce is extremely difficult to take completely out. So we need new ways. And so I became interested in delivering drugs to the brain, because again, this is ultimately a medical disease, right? So convection enhanced delivery is what I used to work on. This is actually work that we did on pigs, where we developed a chronic pump catheter system. It's implanted completely. The patient goes home and for 30 days gets chemotherapeutic infusion directly into the brain, bypassing the blood-brain barrier, all right, and putting chemotherapy all around. You can see we don't get the whole brain, but we get a good amount of it. And it's a refillable pump with a little needle. You can change the drug that you're doing. And so we're writing up the clinical trial. We did 5 human subjects with a completely implantable system. That'll be published hopefully, within the next year. Very complicated surgery, study, but very cool also, right? And then we have bookfar stuff. This is just another paper that I wrote. So convection enhanced delivery here, intraarterial, the green is the chemo. You can see we have to open the blood-brain barrier to deliver the chemo. And this is, again, the future. You can get huge arterial distributions here and change the game. And so there is a lot of stuff coming down the pike with this stuff. It's all, very, very cool. You all need to get into medicine or research or love it or want to cure cancer, because, only with everyone working will we. I wanted to show you this image too. This is a video of, this is a metastatic tumor that I used Fluorescein on. And I think it's very cool to watch. Let's see, we're going to switch to the fluorescence in a second. Someone asked, are there particular journals or podcasts that you recommend? I mean, listen, the big journals are the big journals, right? Cancer research, neuro-oncology, not the Journal of Neuro-Oncology. Those are big cancer journals. JAMA is a big one. Tumor Talk is probably the greatest webinar ever, envisioned by a single human. And so I definitely recommend you guys watch that as much as possible. So you guys saw there the tumor turned green, and now I'm actually operating delicately around it, and you can see how there's some green in the normal tissue. All right, and again, this is Fluorescein. Fluorescein is the green one. Yeah, there's a switch on the microscope. It's actually on my foot pedal for this case. So this is bipolar. You can see the tumor is actually pretty firm, but it lights up pretty green. And now I'm just cauterizing it around it. And you can see actually there where I pull, you can see a little glimmer of normal brain on the other side of it as well. How it changes color. So normal brain under my suction and green on the bipolar side. It's a little blood vessel we're going to take. But again, separation there, deeper in the hole, you can see the normal brain tumor boundary. Yes, the green is, again, it's extravasated in areas of blood-brain barrier breakdown. I wouldn't say that it is cancer cells. 5-ALA is cancer cells, all right? But you can see a very clear delineation there, right? Green versus normal brain. So this is how we use this. I'll show you one more video too, because it's the end of this surgery. And then I gotta run, guys. I'm so sorry. I'm gonna get bad reviews. So here's right, a little bit further down. So this is taking out, this is that same tumor. This is the end of it. You can see again, now all the green's gone pretty much, right? There's some residual stuff around, some of the bleed through, but this is the end of this case where we're gonna cut this last vessel going into the tumor here. I use neuronavigation in combination with 5-ALA. So there you go. So someone asked what protein compound within the cell. So for 5-ALA, it's part of the heme biosynthesis pathway. It's protoporphyrin 9, 5-ALA turns into. With fluorescein, it's not bound to anything. In the blood, it binds to albumin, but with everything else, it's just extravasating. It's extracellular. So anyway, guys, a little bit of a whirlwind. I do have to run because I'm getting about 16 text messages right now. Probably the fastest lecture on fluorescence ever. But I think if I have to tell you anything, it's this. It's that there is very cool stuff happening. Technology is going to elevate medicine to the absolute forefront of science and what you guys can imagine. Artificial intelligence is going to make a huge impact, all right? Robotics are going to make a huge impact. And you just need to get involved and develop a passion for it and move forward. So enjoy. Bye, guys. I got to run.